All right, chapter or section 17, Pediatric Emergencies. Part 1, be able to identify the infant, child, or adolescent with a medical emergency. This is the whole sick versus non-sick that we talked about in the pediatric sim lab. So, if you bring your kid into the ER and they're bouncing around on the exam table, your kid's not sick. Budge up, okay? They should be at their primary care doctor's office the next morning. So being able to identify sick in Dr. Anglin's eyes versus not sick in Dr. Anglin's eyes is really important. Sick being a child with a medical emergency. Now, if there's a clearly broken bone, you are classified as sick. Okay, you get to go to the ER. That is a medical emergency. Respiratory distress, shock, sepsis, asthma, status asthmaticus, status epilepticus, respiratory compromise, lethargy, ingestion, trauma, all of those things put you into the sick category. All right, number 2. Know the initial emergency management of the following. So let's start with shock. Now, initial emergency management of any condition is going to be your ABCDs, okay? Airway, breathing, circulation, disability. It's the same thing for all of them. Airway, breathing, circulation, disabilities. It's the same for adults, for kids. You've got to stabilize your airway. You've got to address your breathing. You've got to address circulation and disability. It's your PALS, your NRP, your ACLS, your BLS, same thing. So whenever you approach test questions for emergency management, the first thing you should think is airway, okay? So when you approach the case of shock, is their airway stable? Are they breathing? Then we get to circulation. Do they have a pulse? Yes, they have a pulse, but it's weak or thready. I should start an IV and give a fluid bolus, okay? That's going to be your next step in management of shock. Now, if it's cardiogenic, you better be careful with your fluid bolus. You want to give it 5 or 10 ml per kilo bolus. Make sure you're using a fluid, taking into consideration third spacing. If it's septic shock or what have you, you're good to give that normal saline bolus. If you're a surgeon, you lactated ringers just because you're a surgeon and that's what you give. You may also need to use pressors depending on their blood pressure, heart rate, and other vital signs. Respiratory distress, those A's and B's are going to be real important, airway and breathing. Do they have a patent airway? If the answer to that is no, then you need a patent airway. Are they breathing independently? If the answer to that is no, then you need to breathe for them. Is it an upper airway problem? If the answer to that is yes, is racemic epi a possibility treatment, or do you need to intubate? Is it a lower airway problem? Do you need to give some albuterol? Do you need to intubate? Lethargic, what's their Glasgow coma score? There is a modified one in pediatrics. I don't think you need to know that off the top of your head unless you're taking the trauma test or the pediatric trauma examination. But if they're lethargic and they can't protect their airway, then it's an airway, breathing, circulation, disability. Those are the things you need to think about. Ingestion, trauma, but it's still airway, breathing, circulation is your acute management. Apnea, you better be breathing for them. Airway, breathing, circulation is your management. Then figure out why. Status epilepticus, you're going to want to manage your airway and your breathing and your circulation, and then you can manage the status epilepticus, control your airway, and then you can treat the status. Remember what we treat status epilepticus with? I'll let you Google it if you don't. Describe the age approach with differential diagnosis and key clinical findings for each of the following emergent clinical problems. And we scroll. Differential diagnosis and key clinical problems. While we do treatment, while we're at it. Airway obstruction. What did it say? Differential diagnosis. So for croup is a viral process. Now there's lots of things that can make you have stridor, but if I say croup, you're going to think viral process, right? And we're going to treat that with racemic epi if you're having an acute episode of stridor, and potentially oral or injectable steroids if necessary. Bronchiolitis is a lower airway process, like metapneumovirus, RSV. Bronchiolitis is excessive production of mucus that gums up the airways. You can treat it with saline and suction, humidifier use, and keeping the babies hydrated. There's no role for albuterol in the treatment of bronchiolitis according to the current clinical practice guideline. Asthma is acute bronchospasm or squeeze of the air tubes. We definitely want to use albuterol to treat that. Albuterol, steroids, Atrovent if we're in the ER setting. Differential diagnosis, there's a lot of different triggers for asthma or acute bronchospasm. Could be viral, could be pneumonia, could be tobacco smoke. Pneumonia, differential diagnosis. Remember your most common causative organisms of pneumonia? Could be viral, could be bacterial, could be fungal, could be tuberculosis. If they have the appropriate exposures or inappropriate exposures, I guess. Foreign body aspiration, we do see that a lot in kids. I pulled foreign bodies out of every orifice that you could have. But foreign body aspiration is a very real problem in pediatrics. Anaphylaxis as a cause of airway obstruction is very real. Treatment for that is your friendly EpiPen, along with Benadryl, steroids, and close monitoring, along with intubation if necessary to control that airway. All right, so next up we have altered mental status. So age-appropriate differential diagnosis and key clinical findings. Altered mental status, so they're not conscious, is pretty much, or not alert and oriented, not waking up to feed if it's a baby. That could be the result of a head injury, which could cause increased intracranial pressure. I've also seen increased intracranial pressure if you have some sort of obstruction along the ventricles, so ventriculomegaly. Usually stenosis along that fourth ventricle. Substance abuse or ingestion. Sometimes it's not necessarily substance abuse, but toddler found pill in the floor of new house they moved into and ingested it. Nobody knows what it was. In fact, nobody knows toddler took it until toddler peed in the cup, and we found it in his or her urine. Infection, encephalitis, or meningitis as a cause of altered mental status. We certainly see that, from birth all the way up. DKA in those type 1 diabetics or type 2 diabetics on certain medications. Low blood sugar in infancy, not feeding well, shaky, jittery seizures, abnormal respiratory rate. Child abuse, trauma can cause altered mental status. Shock, particularly if they're hypovolemic or not perfusing their brain adequately. And hypoxemia, for whatever reason, can cause altered mental status as well. Respiratory distress, respiratory failure, from a variety of causes. Apnea, good old apnea. ALTEs, acute life-threatening event, ALTE, A-L-T-E, ALTE. A lot of ALTEs are reflux or GERD related, which you see a few numbers down. In preemies, it can be true acute apnea, but in a lot of kids, it's not. It's a breath-holding spell because they're refluxing, but to the parent it seems like eternity because they hold their breath and they turn bright red. Red is good, blue is bad, but parents can't process that. They just see something is wrong with their baby and it's very scary to them. Seizures clearly can have apnea associated with them. Respiratory infections, pertussis. Sometimes the first presenting sign of pertussis is apnea and death, particularly in those infants. They'll present cold and blue and dead to the ER in the middle of the night. Those are the worst. And they'll be culture positive for pertussis, unfortunately. So that's why I'm the vaccine crazy lady. Sepsis can be a cause of apnea as well. A very critically ill baby can present with apnea, and sepsis can have such an insidious onset in babies. Gastrointestinal bleeding, man, your differential is broad for that as well. In a young kid, current jelly stool, that's going to be your intussusception. That's going to be a toddler with the doubling over crying abdominal pain. Meckel's diverticulum is going to be your bright red blood per rectum that's painless. In an adolescent, you're going to be thinking ulcerative colitis or Crohn's, which I presented a case of ulcerative colitis today if you were there. Injuries and accidents, we see these things all the time. Animal bites, kids will spook a dog or a horse. I saw a zebra bite one time. I've also seen a stingray sting, which is interesting and thankfully did not involve the myocardium. Minor head trauma. Toddlers bang their heads into things all the time and freaks their parents out. Thankfully, they have very hard heads. Nursemaid's elbow is a strain placed on the elbow that dislocates the radial head. So the grandparents are swinging the babies around. They're holding on to their wrist and swinging them around like this. Or sometimes like the kid will go down the slide and grab the rail and hold on, and it'll dislocate that radial head. And we can reduce that in the office, which is kind of cool. It's cool to be able to fix something and the baby starts using the arm again, or the kiddo starts using the arm again. Shock, sepsis, severe dehydration, decay, congestive heart failure, electrolyte disturbance. We've covered shock a couple of different times, so I feel good that you guys understand that. Describe the developmental vulnerability for poisoning and accidental ingestion in infants, toddlers, children, and adolescents. Yeah, if it's pretty colored, and sometimes even if it's not pretty colored and it's within their reach, it's going to go in the pie hole. That's why we talk about, medicines, drugs, lighters, knives need to all be up high and out of reach. When I was, my oldest son, who's 7 now, started toddling around, he reached up and opened the silverware drawer, and I hadn't even thought that the butter knives were there and he could reach those. Thankfully, they weren't particularly sharp, and I moved them shortly thereafter. But you really have to be very thorough in your child proofing and consider those things. You want to get all your cleaning supplies up high and out of reach, all of your medications. If you have family members that come over, you want to make sure you ask them, are there any medications in your purse? Let's get those put up in our medicine cabinet, because they'll just throw their purse on the floor. Little Johnny goes rummaging and finds grandma's Ativan or whatever, and ends up in the ER in a dangerous situation. So it's really, really important to ask those kinds of questions. All right, I think that's it for pediatric emergencies.